Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. We are going to start off with a really interesting case today. And so this case is pretty in-depth and a bit complicated, but I think there are a lot of different pieces that any runner can pull from when they really go through this episode and learn something about. So this case is a 34-year-old runner who is 3 months postpartum. So this athlete had just had her fourth child, and one of the interesting pieces about this case is that she had gone through infertility treatment prior to having her children. And so we'll talk a little bit further about that. And she had previously had 2 high-risk bone stress injuries before she came in. So she was already somebody that had struggled with REDS and low energy availability previously. She actually had secondary amenorrhea related to REDS prior to getting pregnant. And she hasn't gotten her cycle back yet, but that's okay because that's normal. 3 months postpartum, she's still breastfeeding. So we're not necessarily expecting it back yet, but it is something to keep in the back of our mind. And so the other thing is that running, just like at most runners, is something that she really used for stress relief. She had all of these children, had a really high stress job, and she loved to exercise and run because it really helped to center herself. And she came to us with a femoral neck stress fracture. And so a femoral neck stress fracture, which we'll have Sara go into a little bit more, is one of those high risk stress fractures. And so this is a pretty complicated case, like I said, and it has a lot going on, but we're going to break it down and talk about each of the components and why they're important to consider. And then we'll talk about how we kind of brought this athlete back to running. So I'm actually going to pass it off to you first, Kelsey, because there are a lot of pieces of this case that really relate to nutrition, and I think you should speak to.
Yes, I think this athlete had dealt with low energy availability before deciding to be a mom, and she was a different kind of athlete, lost her cycle, and then she had went through infertility. Infertility can happen for so many reasons, but with the long-standing history of the secondary amenorrhea, it begs the question, was that part of the nutrition puzzle for this specific athlete? And so she reached out to me about 3 months postpartum with the interest of getting back into running, and also the knowledge that there is a nutritional implication with breastfeeding and starting to run again. And so she was doing her best to keep multiple kiddos thriving and get back to work, and just knowing that it was a lot on her plate, and knowing that the knowledge around nutrition alongside really trying to challenge her relationship with food, knowing that she was not going to be able to run how she wanted to until she fueled her body. And so a lot of our time was the logistics of what did she need returning to sport, and supporting breastfeeding, and not just breastfeeding one child, but she had exclusively breastfed each of her children for about up to a year, which makes a difference when it's multiple children. And then she also had a crummy relationship with food, even prior to having her first kiddo. So definitely a lot of things to work on. And definitely as a provider, one thing that I've learned is when you get a case like this, you want to do everything at once, because she's starting to run before she reached out to me before our first appointment. And you want to do everything at once because you just want to protect the client or the athlete. But as far as long histories of disordered eating, because eating is so behavioral, just like increasing running mileage, we have to go slow so it's sustainable. With nutrition intervention, while there's so much I could be doing, part of the challenge was making progress consistently and timely, but also making the information stick so that she could build habits and be consistent. So that's something that I always find really challenging about these cases. I think we have talked about it a little bit before, but with breastfeeding, right now the information is that the nutrition needs are really similar to the third trimester, and nutrition needs can be anywhere from an additional 500 calories per day, or 350 to 500. But the science is kind of emerging and also asking, like, hey, is this more than what we have anticipated in the past? Definitely protein needs go up. Making sure that you're getting in more dietary sources of calcium. That can be a challenge, not in this specific case, but with other cases I've worked on. If the baby has a lactose allergy, is that now we're worried about the mom's calcium intake. There's a lot of things to think about with this. Not to mention mom's exhausted. She might not have a lot of appetite, that kind of thing. And so when we are making sure that a mom that's breastfeeding is well nourished, we're taking into account her basic needs. Now we're adding at least 500 calories of additional calories. This client specifically maybe never accomplished restoration from REDS, even though her body has been through pregnancy. So I just estimated higher with her, knowing that we probably didn't get fully restored from REDS. And then the added cost of the exercise for her. And so we really just worked in places to add more calories, add more bone specific nutrients into her day. And then the logistics of taking care of kids, being a mom, a working mom, and placing these calories where they fit within her day, which a lot of times for me, I'm putting it in the baby's nursery and stuff like that, and other places in her desk drawers, so that if she's thinking about eating, this isn't related to bone stress injury, but hydration is also huge with breastfeeding too, and supporting milk supply. So that's a lot. I'm sure that we might even circle back, but there was a lot to remember with this case because there was so much.
Yeah, I would like to say that this is one of those cases where we really have to work together a lot, because I'm going to let Sara talk before I go through the return to run piece, but I will mention that through every aspect of this, I had to speak with Kelsey, and I had to say, hey, we're going to increase her return to run program now. So I know that means she needs more fuel. Or even the really important piece about working with a team is sometimes they're not ready to hear a certain message. And if you're saying the message and your team member, in this case, if I said something and Kelsey repeated the same thing in a different way, our athlete is more likely to hear that. And this is a really difficult place for an athlete to be, because all they really care about is running. That's all they want to do is run. And there's so many things that we're worried about when we're getting them back that don't seem as important to them, because they just want to run and they want to get back to their life. And it's very frustrating. And it can even be isolating if you can't go out and run or exercise. And so I just wanted to highlight the importance of that interdisciplinary care and really talking to each other throughout this, because without that piece, I don't think we could have been nearly as successful with this athlete. So Sara, I would love for you to talk about what we talked about before this in terms of medications and how that impacts bone stress injury, and just really your input on this case before I go to return to run.
Yeah, so much to think about. And another reason why interdisciplinary care, I think, is it's crucial for this type of thing. You need milestones. You need to make sure everyone's on the same page and hitting those milestones. And when we don't increase our volume until the nutritional piece is being met, and you've got variables. So if they've never had a regular menstrual cycle, even as it's coming back, we know it's going to be different, but we don't know when it's going to come back, what's influencing it. Hormones are up and down. You stop breastfeeding, hormones are still readjusting. So yeah, there's so many variables. And I think about this sometimes with my adolescents too, that lots of variables are happening in terms of growth and sex hormones. And so sometimes there's only so much we can do in terms of what we can control, but I think it's putting the athlete's health first. maintaining quality of life at the same time while we're trying to bring them back nutritionally. So I will make mention again that the femoral neck, highly metabolically active trabecular bridge bone, also a spot that if that bone fracture completes, we're going on to a major life-altering surgery. And so we really want to prevent that at all costs. But any femoral neck bone stress injury should trigger a workup. So when my partners see this, they send them to the runner's clinic and we make sure that we're getting a metabolic workup, we're getting a DEXA scan, we're taking a look at bone density, and we're kind of checking all these different boxes. We want athletes to get back to running and activity as soon as they can after delivery. However, we want to do it safely and we don't want injuries if we can avoid them. So being mindful of all this, and we don't have a perfect formula for this, right? So it's very individualized, as Kate and Kelsey have already pointed out. So one thing that I think is really important to consider, I always mention when we go through a running history that we need to go through medical history too. So what medical problems someone has, what kind of medications they're on, surgeries they've had, allergies, food allergies, alpha-gal is becoming a bigger issue from a tick-borne perspective. So really looking at that big picture. When it comes to medication, sometimes we forget that things as simple as antacids, so Tums, protein pump inhibitors like pantoprazole that they sell over the counter, they can really impact our ability to absorb the nutrients that we need, the building blocks to maintain our bone density. So we talk about low energy availability, but also if you're consuming things that are binding up all of your important nutrients in your gut, you're not able to absorb those either. I know Kelsey also likes to talk about the microbiome, which is super important too. So if you take antibiotics and you strip your gut of all the healthy bacteria, you're also impacting your ability to absorb nutrition and maintain health. So super important to think about what medications you're taking. Steroids can also be impactful, NSAID, so non-steroidal anti-inflammatories, and then also thinking about some of the hormonal things. So if folks are taking medications for infertility, there's a number of them that can impact different things in our body. And sometimes those aren't the first and forefront when you are thinking about infertility. And so you need to ask those questions. You might have a sports med doc who's on your side, a dietitian, a physical therapist who's seen these. So asking and making sure that you are understanding how these particular medications can impact your health. Sometimes we need to be on them for a period of time. Antidepressants are another one that can potentially impact bone health, but sometimes they're appropriate and we need them. But what are some ways that we can kind of mitigate the effects that in terms of what they can impact? I actually recently had a conversation with an athlete who was on Depo-Provera, which is an injectable birth control, and had to remind her that, hey, this can actually impact your bone density. So we want to make sure that we're, if you're doing high volume running, we want to make sure, number one, we're checking the box that you're getting sufficient nutrition to maintain good bone density. But also we might want to check that your bone density is where it needs to be. And if this is not your favorite type of birth control, perhaps being on a different type of birth control that is not known for potentially reducing bone density is important. Now, when folks come off of these birth controls, generally they will recover their bone density. But I think it's so important to consider all these different pieces of the puzzle and what's the best option from an individual basis.
Yeah,
Awesome,
and I'm
Sarah.
remembering as you're talking something that I think I alluded to, but I didn't specify as clearly as I could have. There was actually a meta-analysis that came out at the end of last year that talked about how lactation can alter bone density. And we knew that, but a meta-analysis is a really, really strong proof of scientific evidence where now they have all of these studies that are kind of compounded to make a final decision, which takes a lot of work in science to make a meta-analysis. And so that's really cool that we have that. And that doesn't mean we think breastfeeding is a wonderful thing, but just being informed about what you need to be doing as far as bones, of getting those labs and seeing what the vitamin D values are like, intaking calcium, even if you need to make them dairy-free sources, and then just making sure that the energy availability with all of the demands that I kind of talked about with breastfeeding, returning to sport, being a human, chasing other kiddos around, that kind of thing, those needs are met.
And I think one interesting thing too is sacrum is a really metabolically active bone as well that very frequently can develop stress fractures in these postpartum folks. Oftentimes they have lumbar lordosis, and so a lot of biomechanical things can impact this too, but it can often be chalked up to low back pain or SI joint dysfunction. And so super important that we don't miss that you've got a sports med doc, someone that sees runners that's going to be mindful that could be a potential diagnosis, because we treat that quite differently than we do more functional mechanical low back pain or SI joint pain.
Absolutely. And that's something I want to talk about here too, in terms of like how it shows up and things that we need to look at. So you both mentioned research, and I do want to say that the field right now is changing so rapidly when it comes to female athlete health. And it's really exciting. And that means that there's a lot that we know, there's a lot we think we know, and there's a lot that we don't know. And so we have to really, think about each of these patients individually, continue to dive into the research and learn from one another, again, why interdisciplinary care is so important when it comes to this particular type of patient, even though I would beg to differ, it's every patient. But for this particular case, my job was to bring this person from a place where she really wasn't running, but felt like she was ready to go, like wanted to run a half marathon in the next few months. But she had this femoral neck bone stress injury that she was coming back from. And I had to get her to a place where she was, happy and running and feeling good. And I would like to say that I jumped in after somebody else had already been working with her. And one thing that I noticed, and I do want to point out, is that she was going far too fast. And this is one of the hardest things when it comes to return to run programs, is that you really have to think about it is so individual. I had to really take into consideration her history of bone stress injury, her history of REDS, her history of breastfeeding, her femoral neck stress fracture, and then her actual biomechanics, how she was moving, her mobility and her strength. And then her life, like, is she sleeping? Is she, how stressed out she is? Because stress impacts your ability to heal and your ability to sleep as well. So all of those things are things on my mind when I'm starting to write a return to run program. So somebody like this looks very, very different than somebody that has, a tibial bone stress injury, and they're not breastfeeding and they don't have REDS and all of this. So it's a very different return to run program. And so it was very slow, and she was not loving it. And so part of my job was to really be her cheerleader on top of building out the program and explaining the why over and over again. And so I started with introducing strength, and I backed her off from the strength that she was doing because she continually had some tightness in her hip in the area of the bone stress injury. And it was making me nervous because oftentimes bone stress injuries will show up with tightness, repeated tightness. And she had been cleared to run, but I wasn't comfortable. And so this is someone I actually sent back for another image. And when she got the image, the physician said, oh, she still has a bone stress injury. So we had to back her off even further, which was a huge hit to confidence, and which was a huge hit to just the whole process in general in terms of frustration. It was really, really hard because this athlete didn't particularly believe that she had a bone stress injury anymore, but she really did. And so we had to back her off quite a bit. I'm going to fast forward a few months later. And so she did end up taking the time off that she needed. And during that time, I continued her on strength training exercises that were appropriate for a femoral neck stress fracture, particularly, abdominal work, footwork, those types of things. But then I brought her through a return to run screen, if you will, that looked at things like single leg strength and plyometrics the best that I could. And as long as she's in no pain, then I'm ready for her to start running. And so she obviously had to be cleared by the physician, but that was my biggest thing, is no pain. You cannot have pain when you're running. And so we started with a return to run program that was a run walk, and I paired that with specific strength exercise and some plyometrics. And we started as little as 1 minute of running and 1 minute of walking, which is devastating. When you say, okay, we're ready to run, you can run 1 minute. But we did that. for several weeks. And we eventually built up. I think when we were finished, she was getting ready to run her first 10K. And then we built out a half marathon training program. But I will say there were several bumps along the way and several times where we had to pull back, take a break because of symptoms, and then start again.
Yeah. And I think that what Kate and her team of other PTs are really, really good at is making decisions too, because this athlete was doing quite a bit of cross training on the bike, because technically, stress injury alone, she could do the bike. And maybe her ortho said that she could, but from the root cause was the reds. Something that we had to have conversations was, what is the appropriate amount of cross training that she would get her cycle back in a time that was appropriate, and it wouldn't be stealing energy from her healing, her getting her cycle back and everything, but also weighing in that she's a human working a hard job with 4 kids and just needs that 45 to 60 minutes to take care of herself and loves to move her body, which, I mean, it's fair.
It's totally fair. And that's the balance that we're really working with. And this is why individual return to run programs are so important, and understanding all of the things behind a return to run program, especially with a major bone stress injury like this. But we did, and we worked together really, really hard, Kelsey. I'd be like, okay, can we give her 30 minutes? And you're like, yes, and we'll give her another snack. Or, we really worked together to try and say, she really needs more than this. Can we give it to her? And how can we give it to her so that she's still safe? And then I also calculated for the fact that she wasn't going to completely listen to me. And I want to say that I do that a lot. And, hopefully my clients aren't mad at me about this if they're listening right now. But the truth is as humans, we always want to do more. And it seems crazy when someone tells you can run 1 minute, walk 1 minute for 5 cycles to a lot of people. And especially if you have the history of running marathons or half marathons. And it's just, I calculated so that I knew she would probably do a little bit more and she would still be safe. And that was a constant tension between the two of us. And luckily, it all worked out, and she's great, and she was great, and she worked really hard, and she stuck with it. And that's why she's back to doing whatever it is she wants. But it is a tension and something we really have to think about. I asked her to see a sports psychologist, or at least just a psychologist in general, to help manage this. Now, it's not something she wanted to do because of a time management and also cost. And I understood that, but that was something that we definitely talked about.
Yeah. And I think too, with bones, it's so hard because in that stage, she was doing everything I asked her to do, which was a lot of nutrition, by the way. She was doing everything Kate was asking her to do. And then she potentially went a little too fast prior to going with Kate. But then it felt like for her, she was like paying the cost of like her habits from 2 years ago, 3 years ago, and so forth. So that was a really hard part.
Yeah.
And going along with this, there's some new literature coming out from Dr. Frederickson Lab out at Stanford, where they looked at the female athlete and male athlete triad stratification tool. And if someone had a higher risk score, they actually were able to give an estimate of how many extra days it was going to take for them to return to run. So that doesn't incorporate everything, but it does start to give us some kind of number to look at when we're trying to come up with that formula of how do we get them back in a certain amount of time. But I think it can give us some more in terms of time references to figure out, or ballpark for patients, so they can better understand how long this is going to take. But it's so individualized. I think it's really challenging. One other point I wanted to make too, Kate, that you brought up is, this comes up so often in my clinic, is that fear that, is this pain okay to push through? And the answer is pain is never okay to push through after a bone stress injury, but discomfort, tension, tightness, not feeling like the other side is sufficient for me to be concerned. And 2 thoughts I have. Number one, for these high risk bone stress injury sites, I generally re-image them, especially if they are high risk from a red standpoint, if they're postpartum, all these things that go together. I would definitely have a low threshold to say, I want to repeat you at 2 months, at least 2 months apart in terms of their MRI, to make sure they're going the right direction. MRI findings are going to be delayed. And so they don't have to be totally healed at that point, but we want to make sure things are going in the right direction. Certainly re-imaging Kate, as you mentioned, when she was having discomfort, it just wasn't getting better. Makes a lot of sense. The other thing is with the hip, we also think about mechanics, right? So REDS and all these other things, general biomechanics, but the hip mechanics can be off and put folks at higher risk for having a bone stress injury. So is this the labrum? Is this hip impingement morphology? Is there something else that's contributing? And sometimes we'll even do like a hip joint injection, sometimes just diagnostic with a numbing agent, an anesthetic, to see if that takes away their pain. So is this joint pain? Is this bone stress injury? That's a combination that oftentimes we're trying to sort out, which is why it's so helpful to continue seeing that sports med doc as you're getting back into your return to run plan, in case these aches and pains come up and we decipher, is this dangerous or is this something that it's okay for us to kind of work through? But especially high risk sites, I don't mess around with those. I make sure we re-image, and it sometimes, unfortunately, it's still there. And I want to give folks peace of mind, but I also want to treat it if it's still actually a bone stress injury that needs to be managed. So
I would actually like to yell this from the rooftop, Sara, because you're the reason that I often say, hey, have you talked to your physician about getting another image? Because of cases that we've worked together, just our discussions. And I would like to say that a lot of times physicians don't want to order another image, or because of insurance, they don't want to order an image. And I find that my patients are often having to fight for another image. And I wanted you to kind of speak to that, because I hope that there's physicians out there that are listening to this and they're really thinking about it again when they have a case like this, because it is so valuable. Because the last thing I want to do is continue to push someone in a return to run program when I have the gut feeling that something is going on and this tightness is recurring. I would much rather have a clear, like, it's definitely not Kate, it's something else, keep going. But could you speak to that from your physician perspective? Because I do find that a lot of people are getting pushback from their physicians.
yeah, I generally don't have a problem getting that second MRI approved. Occasionally, I'll have to do a peer-to-peer, but I can usually make a sufficient case. And for someone like this, I would have gotten labs. They're probably seeing a dietitian. They're seeing a physical therapist. We've potentially had delayed healing. We have REDS as a diagnosis. We have potentially anemia or low ferritin. So I generally have a pretty big diagnostic list that I'm able to submit to the insurance company and say, hey, this is a high risk injury and we really need to make sure that things are getting better. And if they still have pain, it is worth re-imaging because of the possible consequences. And the insurance companies don't necessarily care about the consequences, but when I can argue all those different points and those diagnoses that I can put in, REDS is actually CPT code now. So I can actually put these in, or ICD-10 that I can put in that really helps make a case. So I really haven't had an issue with it. As long as we're at least 2 months out, it's sufficient. Occasionally they'll say, oh, hey, you already had an MRI. And I say, I know, but they still have pain and we're 2 months out. We want to make sure that they're cleared to get back.
Thank you for that. All right, guys, I think this has been a really interesting case to talk about. And there are a lot of things, again, even if you're not a postpartum mom who's breastfeeding, there are a lot of pieces of this case that you can listen to and learn from the nutrition piece to some of the diagnostics that you were talking about, Sara, to definitely some of the return to run. So do you each have one thing you want to say as a take-home message today?
So I'll start. I think the really cool thing about this case, and I think this was very Kate and Kelsey heavy case, is watching you both present this and the words that you use, like devastating, and how impactful these things are on a woman's life in a very hectic time in life, which really cool time in life, right? Like you've got babies coming and you've got young kids and you're still marathoning. I mean, that's a lot of good things that are happening, but it's really impactful in someone's life. And I think, one thing that I think I really want listeners to take away from this is we're here to support you. We want to get folks through all of this, but we also take it really seriously. And so when we say things like devastating, we understand that it's a big deal to not be able to do much of that running when that's a big part of quality of life. And so, I really want folks to develop rapport and see us as support, right? So we're here to get you back to running, not to shut you down. We shut you down because it's what's safe to do, and we want to make sure we get everyone back to running and doing what they want to do and love. But it's so high high impact on people's quality of life that, it's why we're all here today, right? Doing these podcasts because it's a really big deal. And there's so much that I think we have to offer that sometimes can be looked over in our general kind of reactive healthcare model.
Hear, hear, Sarah. Hear, hear.
I don't want to go after her.
I don't either. God, Sarah, stop being so good at what you're doing. Just kidding. Go ahead, Kelsey.
Well, I said I didn't want to. No, I'm just kidding. No, that was so beautiful, Sarah. I also really appreciate that, like, while not being able to run, devastating might seem like a strong word, relative to the other cases you've seen in that day. In her world, it really was devastating. So it's awesome when you're able to see that and just know that everybody's going through something and it's hard no matter what. I just think that I really love thinking about the process of lactation because I think that the biology behind it is so cool that the baby's always going to get the nutrients first. And so if that means calcium being leached from the bone or iron or stuff like that, whatever, wherever the baby is in the stage of development, if the mom's not eating enough for both, the baby's going to take priority by laws of biology. And so just remembering that. And if you have the resources to work with a care team postpartum as an athlete, then, I would always recommend that because you're asking your body to do a lot.
Yeah, that's great. I would say, like I said already, that every return to run program is very individual. And so you can't just assume what your friend did to return to run postpartum or return to run post bone stress injury is what you need to be doing. And you really do need to work with someone that understands all of the pieces that come into play when it's talking about your return to run program. So it's not as simple as saying, let's run 1 minute, walk 1 minute, run 2 minutes, walk 1 minute. There are a lot of generic programs out there, even in research papers, which are great because it gives us a bottom line to start from. But if someone just hands you a generic return to run program, then it may not really be the best case for you. Sometimes they work, of course, but in general, make sure that you have a team that really understands or a person that really understands all of the biology and everything that's happening with you, including the biomechanics and the strength components. All right, everyone. Well, thanks for listening. And as always, please share this with other people that you think might benefit from it, with coaches, with other runners, your run club, your morning coffee, whatever it is, whoever you're talking to, please share this because that's how we spread the word and that's how we help more people and more runners stay running is by people listening and learning from this. So, like us, follow us, all those things you do for podcasts, we would really appreciate it. And if you do have questions, you can always email us at runcasemiles@gmail.com. And we are going to be answering some questions further down the road in this podcast, specific questions in short episodes. And we would love it if you would send us specific questions for us to answer instead of us always having to pull from our patient cases. So take care and we will see you soon.